I know some really good stories. No, I'm kidding. Dr. John Petty completed his surgical residency at Oregon Health and Science University. After he completed his fellowship in pediatric surgery at Denver Children's Hospital, we were fortunate to have him join the faculty at Brenner Children's in 2005. He has stepped up to the plate as the director of our Pediatric Trauma Center, and under his guidance and leadership, Brenner Children's has achieved distinction in becoming, I love to say this, North Carolina's only level 1 pediatric trauma center. Yay. So, good job there. He gives his time and advice freely to other centers who also are working towards becoming pediatric trauma centers, because we don't want to keep it all to ourselves. We want everybody to be giving quality care to children. He is a very much in-demand speaker on pediatric trauma and pediatric surgery, and I think he may need an agent soon, because they email me and say, can Dr. Petty speak at our conference? So we're happy to do that. And I've heard him say to many people that he has the best job in the world because he gets to work with kids every day. I mean, how great is that? And I feel the same way, but that's with the added bonus of getting to work with him every day. So it's my pleasure to introduce Dr. John Petty.
Thanks, Ginger. You said that just like I wrote it. All right, man. Oh, let me switch my little robot guy on here. Hang on, everybody, we're almost done. We're going to try to keep it lively. The best is yet to come, and it's certainly not my talk. It's the family that's going to come next. But we're going to work through some cases, and I hope that you all will help me out with some questions and answers, and what do you do about this, and what do you think, and that sort of thing. These are sort of a little bit from the lunatic fringe, and I was talking with Dr. Busey at the break. You know, it's kind of one of those things that it's really the nutty stuff that kind of pushes you to places you might not otherwise go, that makes you better at the stuff that you do every day. You know, it's when you're sort of challenged and have to rethink or go back to first principles or whatever. So there isn't any one of us that wakes up any morning and says, you know what, I hope some disaster thing happens, you know, at my hospital today. And yet we all get put in those situations. And so take a deep breath, take your own pulse, and just sort of say, here we go. So anyway, we're going to work through some cases. They may be patients who are familiar to some of the folks here. This ought all be de-identified, and I think I've done my diligence on all that. Some of these things are memorable, but it's going to be a chance just to work through some stuff, and I will try to be sure that we end at, what are we talking, 3:30, something like that? Where'd Ginger go? Is that about right? Okay. As it gets close, you can give me the signal, and we'll fly through it. I've never been accused of talking too slowly. I mumble, but slow is not usually a problem. So we're going to sort of expound upon a little bit of the stuff that Dr. Pranikoff sort of set the scene for. And I did just sort of want to bounce to one question that came up about at the sort of initial emergency department, what do you do for dressings? My only sort of addition to that is don't leave a child in something wet, so that you can have pretty significant heat losses in that. So there was a time where I think wet gauze was sort of perceived as sort of the right thing to do. So whatever the outer layer it is, whether it's, you know, Silvadene or Bacitracin or peanut butter or whatever, just that the outer layer is something dry so that they don't get cold en route. So, but we're going to talk about a burn case here, focusing on the smoke piece, which thankfully you don't see. This is a 2-year-old girl who was at her grandmother's house, and there was it was nap time. She was in taking her nap. There was a fan on the floor, and there was some version of an electrical misadventure with this. And it caught fire and caught the house on fire. And so EMS showed up, and I don't know who here is involved with EMS. I was talking with someone at lunch who did sort of rescue for a summer. But this was a brave person who went into the fire to get this child out, because it was made clear to this person that the child was inside. So everything downstream from that is a save, you know, thanks to somebody who had the courage to go in and get this baby out, or toddler, I guess. She was initially unresponsive, and then during the course of some sort of resuscitation at the scene, she became arousable and appropriate. But because of her physical appearance and because of the circumstances of the fire and the smoke, the decision was made, I believe rightly, to intubate her and bring her on. So she was stable en route from a standpoint of oxygenation and age-appropriate vital signs. There was past medical history gathered from family members at the scene that she was on an antibiotic for some sort of a skin rash, no surgical history or medication allergies, and she was brought in because of the airway and smoke inhalation as a level 1 trauma activation. So we're going to talk a little bit about inhalation injury. There was, I think, sort of one slide that sort of built on that. We thankfully don't see a lot of inhalation injury, but when you do, you can't just sort of make it up as you go because it's a pretty serious thing. It is probably the major cause of death in burns. That is, he had a nice slide about sort of risk ratios for that. Inhalation adds a significant risk of death to an otherwise survivable burn. So there's about 5,000 to 10,000 deaths every year related to inhalation injury, and probably about 23,000 more injuries that are non-fatal related to inhaling smoke or other products of combustion. About 30% of all sort of burn patients, and this would be the flame burn patients, have some component of inhalation injury. Not all of them sort of at the most severe end of things. And so this sort of recapitulates some of the stuff Dr. Pranikoff had already said. For an isolated thermal burn, the mortality for that, all comers, is about 1 to 2%. If you add a serious inhalation injury to that, your mortality can go up as high as 40%. So in children, this is sort of the mortal factor. I mean, we don't see a lot of these 90+% burns, thankfully. Most of what we see are sort of smaller things. Most of what we see are hot water scalds or sort of kitchen misadventures. But when you see this, the stakes are a lot higher for survival in a way that most of the burns that we take care of are not. And so what is a history that gets the little hairs on the back of your neck up for inhalation injury sound like? Because not all the sort of gas on trash, it sort of flared up, or I kicked the aerosol can into the fire at the campsite, or whatever the story is that might have been dramatic. Those are not patients that are particularly at risk for inhalation. Probably the biggest one would be smoke exposure in an enclosed place. So it's not that you can't get an inhalation injury outside, it's just a lot harder to actually pull that off. But if you're in a structure of some sort where smoke is accumulating, that's the thing, probably, I would say more than anything else, that ought to say, you know what, this is a lot more serious than different circumstances that you might see. Prolonged exposure to smoke, patients who are physically or mentally impaired, again, you might not know their story when you're seeing them, but patients who have a decreased ability to rescue themselves, i.e. a 2-year-old who's in a house fire with an electrical fan that blew up and started to smoke, or is that acquired, that they've been exposed to the smoke long enough that they've actually had a decreased level of sensorium because of the inhalation component. Fire conditions and fuel, so what is burning changes the risk equation a little bit. Sort of natural substances, the wood, bark, the outside campfire stuff, compared to a lot of the stuff that's in our furniture and in our paints and in our plastics and that sort of thing. There are a lot of sort of things released in those smokes that are more noxious. So again, it would be the sort of burning house sort of furniture sort of thing as opposed to the wood fire, that sort of thing. Explosions, again, there's a major heat factor to airway burns. Most of the heat is dissipated before it gets to the lungs, but for the upper airway stuff, the heat exposure is a big deal. Steam, it would be the exception to that. So steam has the capability of actually carrying heat down into the lungs and into the lower airways in a way that sort of dry exposures don't. Caustic fumes, again, if you're at the chemical plant or the furniture varnish, production line and it catches fire, there's a lot of things that could be released there. And a patient with pre-existing pulmonary disease is obviously in a high-risk category, exposure for exposure. And then aspirated or swallowed hot liquids. So this is a patient who would sort of fit the bill for at risk for an inhalation injury. So what do patients look like that are at risk for inhalation injury? Well, respiratory distress, I mean, that's sort of the tipping point for any one of a number of emergencies, somebody who's actually before your eyes going down the wrong way. So regardless of necessarily the circumstances, you may not know all the circumstances of that, but somebody that's working hard, one of the bird surgeons who trained me said, if you're thinking about intubating somebody for smoke inhalation, you probably should have already done it. That sense of there is a velocity to these things in terms of edema. where you might lose a window of safety that you wish you could do over again. So soot all over the face or in the sputum. Again, the aerosol can and the campfire that flashes up, you might singe your eyebrows or something like that. It might be dramatic, but the likelihood of having actually inhaled much of that is pretty low. Burns over the face or neck, obviously extremity or other burns are not sort of airway smoke inhalation injuries so much. Singed facial or nasal hair, oropharyngeal burns. So looking in somebody's mouth can tell you a lot rather than just sort of what's on the outside. But is the oral mucosa, is their palate and their oropharynx, is it red and kind of beefy and angry, or is it sort of normal appearing? Tachypnea, again, in the category of respiratory distress. Hoarseness, that would be injury to the cords, either from heat or from the chemicals in the smoke. Stridor, that might be sort of the last thing on your way to apnea or arrest. Drooling, and signs of airway obstruction. So just to sort of reinforce that. So again, you see a patient like that, you can say, this looks like a guy who might have inhaled something bad. This looks like a guy who didn't inhale. Anyway. Sorry. It's an election year, come on. All right, at least we're still awake. So you look in this guy's mouth and you say, I wonder, right? So, again, we don't all have little signs on our head, inhalation injury, but a guy like this, I think, we would all agree is at risk for that. So the upper airway, this is the kind of the front lines. These are the first things that are going to kill you from inhalation injury, or the upper airway sorts of things. There's sort of the inhalation injury is sort of, you can break it up into different sort of components, even though it's all one event. But there's the heat bit, the upper airway, there's the chemical irritation, and the systemic things, that which gets into the bloodstream and can kill you too. But this is the sort of most emergency of the emergencies, would be the upper airway stuff. So thermal or chemical irritation from the vocal cords on up is sort of where that occurs. And this is a laryngoscopy, and this may be a view that a lot of people in this room see on a regular basis, but you can see these are sort of the true cords, but the false cords, the arytenoids, these are red and swollen, and this is trouble brewing. If you can get a tube through here, your patient will thank you forever. So blistering, ulceration, hemorrhage, edema, the heat denatures tissue protein, so the structure of these sort of anatomic landmarks may not be the same in terms of friability and irritation and how many attempts you may or may not get to do it. It activates complement, so there's a systemic piece that can come from a local injury from the upper airway. This is not our patient, but it could be somebody like that. So back to our patient. Had age-appropriate vital signs, a pulse of 143 and a good blood pressure, and was 100% saturation on 100% FiO2, and had these, again, physical findings consistent with a smoke inhalation, soot around the nose, mouth, and then from the endotracheal tube. So once you're in the airway, what do you suck out? That will give you very helpful information about how severe or not the inhalation is likely to have been. And of course breath sounds on exam. So this patient also had burns. This is not our patient, but certainly could be. These are sort of mixed depth burns. I think one of the challenges of sort of assigning a percentage burn to a patient is they don't come in these sort of, I put my arm in the hot fire and I had a asbestos sleeve, up here, so I just burned, 9% of my arm. They usually are sort of patchy and splotchy, and the vectors of the heat exposure are different. So you might have areas like this that would be full thickness, where it's sort of dark brown and leathery, and then this stuff over here that's probably in the category of a superficial partial thickness because it's moist and painful, the blisters, all that sort of thing. So burns don't sort of come, in nice little blocks, that would say, if you sort of measure 10 centimeters by 10 centimeters, that gives you an easy math equation. So they usually come in sort of irregular shapes and configurations, which adds to the challenge. But these are burns of variable depth, which I would say is our most consistent pattern. That is usually for the burns that we see, it's not all one depth all the way around a fixed area. So these were, this patient had a badly burned left arm. This is not, again, our patient. But the particular sort of burn emergency for this patient had to do with a hand burn, which this patient developed actually a hand compartment which was astutely diagnosed in the emergency department by sort of the folks who were there, with these sort of cherry red fingertips and a hand that was in the position that I think orthopedic hand surgeons and PTs and other would call it intrinsic minus, which is this, where the metacarpal phalangeal joints are held in extension and the PIPs are in flexion. And that has to do with tightening of the compartments around the fingers, and you can actually get tightness of the collateral ligaments. And so the treatment for that is escharotomies, and in this patient it was actually also to perform forearm fasciotomies in an attempt to save the hand. So here's a patient who's hypoxic and soot, and the house exploded, and everybody's in crisis or whatever, and the bit of actually sort of assessing a hand in a patient who's not going to tell you that it hurts, so they can't really give their fingers when they say do this or that, but to realize that piece of an emergency in real time takes some thinking, and I think Dr. Molnar is the hand surgeon who was on that day. I think he deserved a lot of credit with this child still having a hand. This patient had burns to the right chest that were not particularly consequential in terms of size or depth, and then a few spots on the face too. So what do you do in the trauma bay, right? You're trying to keep your priorities straight, A, B, C, D, E, and all that. But because this was a structure fire, unknown what was going on at the time to make the fire happen and what happened to the child, burn patients like this, smoke patients like this are also trauma patients. So even though, again, they're sort of black and sooty and they don't have any eyebrows, you don't know if it exploded or if they fell or what it was that started the fire. And so in the absence of a convincing sort of witness or history, you have to assume the possibility of injuries that are completely unrelated to the hot things that were going on at the same time. So getting a chest x-ray, obviously, both to check the endotracheal tube, but also to look for other injuries as well. Pelvis x-ray is a fairly sort of standard thing to do in the trauma workup. We got a CT of the head. This is a child with an impaired level of consciousness and sensorium. Was it a blow to the head, and something that Dr. Powers might want to be involved with from the get-go? Maintaining C-spine precautions, evaluating the C-spine. We also sent labs that showed that, at least at this stage in the resuscitation, there was not evidence of significant hemorrhage, but there was a deficit, a tissue deficit like lactic acid, because there's not enough oxygen getting to the tissues, and so they go into the anaerobic metabolism. Our initial blood gas showed a very good PaO2. That's an encouraging sign to see. And then approximately sort of 3 hours from the event, we sent off a carboxyhemoglobin that came back at 1.1%. So this is getting, from the hot bit to the upper airway to the chemical bit to the lower airways and lungs to the systemic absorption of carbon monoxide. We'll talk a little bit about that. So that the half-life of carbon monoxide in the bloodstream is a function of how much oxygen is there. These things compete with each other for hemoglobin. And so on 100% FiO2, the half-life of carbon monoxide is about 90 minutes. On room air, it's about 300 minutes. And if you put somebody in the hyperbaric tank, it's about 30 minutes. And so the bit of giving somebody from the get-go at the scene with smoke 100% FiO2 is the right thing to do for a number of reasons. One, you don't want them to turn blue and die on you on the ride to the hospital, but it also helps with this bit because you start those half-lives earlier to clear the carbon monoxide out. It has about 240 times the affinity for hemoglobin that oxygen does, so it's an uphill battle. So moving down through the airway to the lung injury, you get chemical irritation and injury to both to the airways, the sort of primary, secondary, and tertiary bronchioles, and also to the alveoli themselves. And these are a lot of the same processes: injury to the epithelium, thickening of the alveolar capillary membrane, inflammatory infiltrates, exudates, all those sorts of things, plugging, goo, goobers, soot, and nasty stuff that plugs up the airways and keeps the air from going in and out. It can give you atelectasis and ultimately pneumonia, and impair your gas exchange. So these are part of the reason why people struggle to breathe when they've had significant smoke exposure. This is a slide that just shows a small bronchiole. These are alveoli, but this is a bronchiole with the sort of pseudo-columnar ciliated epithelium or whatever the lingo is. And this is probably fibrin. These are polymorphonuclear leukocytes that are sort of plugged. What's supposed to be in here is air, and what is in here is goo, and you can't breathe through the goo, and this is a result of a significant inhalation injury. And so what do you do about that? We'll talk about that in a second, but at some level it becomes a plumbing question and not advanced biochemistry experiment. So the systemic toxicity, I just touched briefly on carbon monoxide. So it binds to hemoglobin, both in a competitive way. The sort of heme molecule in hemoglobin can hold 4 sort of oxygen molecules, and so it sort of fights for those. But once a CO, carbon monoxide molecule, attaches to heme, it changes the conformation so that oxygen can't be released from that same molecule. So there may be oxygen on your hemoglobin, but if it can't get off, it's the same as not being there at all. So the bit about the guy in the garage who turns on his car and turns cherry red from carbon monoxide poisoning from a suicide attempt, the reason they're red is because there's oxygen on their hemoglobin, but it's not able to get off of the hemoglobin and get to the tissues and do what oxygen needs to do, which is drive aerobic metabolism. So it sort of gets you on 2 fronts. This is a graphic depiction of that. This would be a sort of a normal oxygen dissociation curve. So as your sort of partial pressure of oxygen goes up, you should have higher sort of oxygen content in your blood as a function of your hemoglobin. This green graph here is if you sort of had 50% anemia. So if you lost half of your hemoglobin volume, you would have half the content of oxygen there. And this is what 50% carbon monoxide does to your hemoglobin. It's the double whammy, right? So it sort of chews up half of your hemoglobin to be non-functional, but it also changes the ability of that functional hemoglobin that you have left to release the oxygen. So it shifts the curve to the left so that in order to unload the oxygen, you have to have a higher and higher oxygen tension. And that's the danger bit for carbon monoxide. You can also have cyanide released in smoke, and that binds to one of the cytochrome A3 or something like that in the mitochondria, and it's an irreversible reaction there that keeps you from being able to metabolize oxygen and make ATP and keep all the good things going in your cells that need to keep going. And then there's all sorts of other nasty stuff, right? There's sulfur and lead and arsenic and who knows what else in smoke that can be absorbed into the bloodstream and cause its own sets of havoc. So this is a similar graph about how do you manage the airway in somebody where you suspect a smoke inhalation, and a lot of this is very straightforward, but I tell you, in the heat of the battle, you go back to your first principles. It's A, B, C, D, E. So again, the ATLS protocol, again, house fire, smoke, inhalation patients are trauma patients as well. But sort of a history and physical exam, there is clearly a group that needs immediate intubation, and some of those patients will be very apparent within fairly short order. But then there's this group that has the story, or they're in the situation, but they don't look so bad. If you can take a look both in their mouth, but also at their cords, you might say that this looks all right, and we'll admit you, and we'll observe you and see how you do, and if you get into trouble, we'll intubate you, and if you don't, you'll be okay. So you can take a look at their airway, and again, if they're borderline, you can watch them for a while, and if they do all right, they'll be okay, in sort of a statement of the obvious. But then there's a group that will ultimately decline from edema, or they get tired, right, because they're breathing so much harder against all this airway obstruction. So this is a sort of a bronchoscopy picture of what inhalation injury might look like. So this is the carina. I can't tell which is right and left for the main stem bronchi, but bad things are afoot at the Circle K in the airway here. So how do you treat airway injury? We'll not spend a ton of time on that, but some of these things are just the right thing to do for all kinds of airway problems. So the cornerstone of it is not some magical antidote that's kept on a hidden shelf in the pharmacy that has to be released with the hospital administrator on duty, but it's oxygen, right? And it's supportive care, it's bronchodilators if they have bronchoconstriction, it's suctioning and pulmonary toilet and that sort of thing. So again, supplemental oxygen, both for they need oxygen, but also for the cyanides and the carbon monoxides of the world. Bronchoscopy is helpful early on because it can get you a sense of perspective of, is this a extubate in the morning kind of kid, or is this we're going to be here for a couple weeks kind of kid? Because the soot and stuff will clear usually fairly rapidly, but if you see a ton of it early on, you know you're in for a fight. Bronchodilators, again, to relax the smooth muscle in the airway so that you can get the goo out, right? It's the sort of plumbing model for airway management. Hyperbaric oxygen, so the indications for this are a little bit of a moving target. So a carboxyhemoglobin, so that our patient had a carboxyhemoglobin of about 1.1 3 hours from the event. So if you sort of work backwards, if they were getting 100% oxygen fairly on, that sort of peak level was probably around 8%. Smokers sort of walk around with a carboxyhemoglobin level of 10 to 15%, or 10 to 13%. 15% is sort of considered toxic, and on you go from there. So hyperbaric oxygen as a sort of rescue therapy, most people would say somewhere around 25% carboxyhemoglobin and signs of organ dysfunction. So patients that are not oxygenating well in the face of that. The thing about HBO, and here's the little Michael Jackson tank that you can go into, is once you're in there, you're there. So you can't be hanging blood products and sort of cranking up this and that, or doing a lot of other things while they're in their dive. So it's generally a modality that for its usefulness, and I certainly would say that it probably has a place, is for the more isolated inhalation folks, not the multi-trauma, sort of bleeding to death, we need to find another IV and hang another bag of this kind of patients. Aerosolized N-acetylcysteine mucomist probably has a role. It breaks disulfide bonds and makes the thick stuff thinner and easier to get out. Some people also use aerosolized heparin. There's a protocol from Galveston looking at inhalation injury in children. They use those two things routinely for smoke inhalation and report good results. There probably won't be anybody that gets a better series in a place like that. So for patients that you're going in the wrong direction, you might consider doing that. Are they not hearing me in the overflow room?
Yeah, I was wondering if I could take your microphone for a second.
Oh, okay, sure. Can you hear me now? Seems like it's working. All right, sorry about that in the overflow room. We'll get our sign language interpreter up here shortly. So steroids, again, for the inflammatory part of the smoke inhalation are probably the wrong idea. Steroids increase your risk of infection, and particularly in somebody who also has a burn, you increase your susceptibility to infection. So it seems like a nice idea, but it's probably actually the wrong thing to do. Same thing with antibiotics. There's sort of no value in sort of prophylactic antibiotics for inhalation injury. It's not an infection problem. They are at risk for adolescents and pneumonia. If they develop a pneumonia, they ought to be treated with antibiotics. But you probably just select out for resistant organisms for the day that pneumonia comes, or for the day that their burns get infected with fungus or something like that, because you've shifted the patient's flora in that direction. So again, not as a frontline treatment for inhalation injury, not really as a treatment for inhalation injury at all, but as a treatment for pneumonia, antibiotics would be appropriate. So this patient was admitted to the pediatric ICU. Here's a little photo. This technology, it was called a flow sheet. It was this crazy piece of paper that would fold up, and with this thing, they would put ink on it that would say, yeah, so there goes the flow sheet. It's all electronic now. So anyway, he was seen by the hand surgery, the plastic surgeons who did escharotomies and fasciotomies of her hand. This is not her hand, but this is not unlike what hers looks like. And these were sort of the cherry red little fingertips that were there. And again, the hand that's sort of stuck like this because there's so much edema and swelling in a fixed compartment that they lose flexibility and can lose fingers or even the hand. Regarding the inhalation injury, this patient actually did fairly well, was on the ventilator for about 6 days, had multiple operations for the hand salvage, but did well with the other burns. And it is still in rehab. Is follow-up even just a few months ago with Dr. Molnar for contracture releases and scarring and that sort of thing too. So this is the emergency within the emergency. But she went home 25 days later and still following up with hand therapy. Any thoughts on smoke inhalation or questions before we move on? Okay, well, I will keep moving. So here's our little girl on her bicycle. Now, yeah, who wouldn't have wanted to do this, right? I mean, you get this stuff from the AAP, and it's like it's just this grumpy bunch of folks saying, no, no, no. So anyway, what can you do as a kid that's safe and fun and all that? We've got to help kids make good decisions. But I think bikes are still on the list, thankfully, but maybe after this we'll think differently of that. So it's a time for a unicycle. So this is an 8-year-old girl who was in a bicycle crash. It's a patient that Dr. Pancreatic took care of. She was, sort of a change in surfaces from the pavement to the grass, lost control, over she goes. And she flipped over the handlebars and landed, thud, with an impact at the end of the handlebar to her epigastrium. So here's the weapon of mass destruction here, the handlebar, which is why we need unicycles for our kids. No handlebars. So she didn't hit her head, she didn't pass out, she shook the cobwebs off, got back on her bike, and home she goes. So this is about 3 o'clock in the afternoon. Mom's there with her, kind of watching her. About 3-4 hours later, she starts to get sick, belly pain, throwing up. Something's not right. So off they go. So she went first to a referring facility where she was evaluated, and she was noted to be well-appearing, stable vital signs. All of that, had some pain and some nausea. This is not her abdomen, but it well could have been. So you kind of do the once-over at the top to bottom. The E in ABCDE is exposure. Take a look at them, look for the hidden bullet holes or all that kind of stuff. But there are no bullet holes on this girl. She did have this, a little sort of circular, end of a handlebar-sized abrasion on her upper abdomen. And that was it. So thankfully, on their way to the hospital, they stopped at Barnes & Noble, and Mom picked up a copy of Cooper Gets a CT Scan. So for your pleasure reading, they got some labs on her, and notable among the labs was an elevated lipase. And she got a CT, which is a very appropriate intervention for a patient with that physical finding. So everything looks great except this one little quarter-sized red disc on their belly. You think, why are we getting a CAT scan? She's just throwing up because she's worried or she's sore or whatever. But that mechanism tells a deeper story. So these are some slices of her CT scan. This is her liver, spleen, stomach, aorta, vertebral bodies, front, back, right, left. Coming down, we see her left kidney here. This is the splenic vein, and this is the pancreas. And what we see here on this cut is that there's a well-perfused sort of, head, neck, most of the body of the pancreas, and then part of the body and tail is well-perfused, but you see this little crack that goes through here. Coming up to the splenic vein. Shows up even better on this slice here, sort of fault line between the tectonic plates of the pancreas here, and off she goes. She has a transected pancreas, which is a potentially pretty serious injury, and the story goes like this. Sally Sue was on her bike, she fell and she got hit with a handlebar. So pancreatic injury is not the most common abdominal injury that we see. It's present in some form or fashion, probably about 2% of our patients, but most of these pancreatic injuries are sort of nothing injuries. It's only about 10% of these that have an injury to the duct, and that's probably the most important component of the pancreas, because if the duct is transected, you can lose all kinds of nasty stuff out of the pancreas that can make you real sick. So it's not a particularly common injury, and any given center doesn't see 20 of these in a year. The mechanism for it, so penetrating injuries are rare in children for this. Probably a third of pancreatic injuries in adults are from a penetrating mechanism. And the top of the list for how these injuries happen is the bike. And usually it's the handlebars of the bike, not the kickstand or some other part of it. But you can also see them in other forms of sort of generally blunt trauma. Fall, ATVs, kicked by a horse is on the list as well. I guess that would count as assault maybe. And because these aren't usually kind of blood squirting everywhere kind of injuries, it's not uncommon for them not to sort of appear right out of the gates. And so the average time to presentation is somewhere between 2 and 3 days for these. There's a grading scale for pancreatic injuries that's sort of devised by the American Association for the Surgery of Trauma, the AAST. Grade 1, 2, 3, 4, 5. The 1s are sort of the nothing, little bruise to the pancreas. The 2s are bigger bruises. The 3s are the transection of the pancreatic duct. And then the 4s are more proximal in the pancreas, where the duct drains into the duodenum, and there's sort of the high rent district there. And then massive disruption of the pancreatic head. So these are prognostic for outcome in relationship to pancreatic injuries. So operative management, this patient was taken to the operating room within the sort of first 24 hours of her arrival. At operation, she was noted to have a large amount of ascites, saponification, the sort of turning to soap of the fat of the retroperitoneum because of the pancreatic enzymes that are released around it, and a complete transection of the tail of the pancreas. So she had a spleen-preserving distal pancreatectomy, sort of with a pen and ink sort of drawing. This is more pancreas than this patient lost, but it just sort of illustrates what you leave behind is the neck, the head, and the enzymatic process of the pancreas, and you preserve the spleen. The pancreas gets blood supply to the distal part of the pancreas from the splenic artery and vein, so that's the technically sort of most challenging part of that operation. And then a drain was left behind because you close the remaining pancreas with a stapler or with sutures, but there's all sorts of little microscopic ducts that are there that will drain until they scar and come closed. So controversies about the management of pancreatic injuries, and they're uncommon. So any given center has its own sort of practice regarding this. And unless you're seeing 50 of these a year, it's hard to say, well, we'll do half of them this way, half of them this way, and we'll see which is better. So there is sort of controversy out there about the value of operative management, i.e. going promptly to the operating room, taking out the injured portion of the pancreas and leaving the remainder behind, versus non-operative management. I think one of the things that goes into this is, do they have other injuries? Do you need to be in the operating room exploring a child's out because of a bowel injury, in which case it's hard not to do something about the pancreas as well. ERCP, we don't do many ERCPs in children, and the smaller you are, the harder it is to do, but this is a way to interrogate the pancreatic duct. So if you can diagnose with ERCP an obvious duct injury, that pushes your hand into this is a grade 3 or worse pancreatic injury. And then the outcomes for operative or non-operative management, they're sort of all over the map, and it's a little bit of apples to oranges. How do you gauge a longer length of stay versus a pancreatic pseudocyst versus a fistula or a bowel obstruction because you've had an operation? So suffice it to say, there's not conclusive evidence, but the two biggest studies, this is one from the American Pediatric Surgery Association that was sort of a multi-institutional survey. How many pancreatic injuries do you see? How do these kids do? And then they pooled all their data. And the two groups were not sort of equal. There was a group that had operative management and a group that had non-operative management. But you can see this is, I think, 5 major children's hospitals, and between all 5 of these, over 5 years, they had 43 pancreatic injuries. So the numbers are low. And so the operative group had one set of complications, a lower incidence of pseudocysts, but a higher incidence of operative complications like bowel obstructions or wound problems or that sort of thing. Days in the hospital were about the same, 14 to 16. There was no significant difference. And then this is a 10-year series from Children's Hospital Denver that had 14 in the operative arm and 11 in the non-operative arm, and it sort of shows the same thing. So this is sort of an area of inquiry. I'm not sure that we at our center will answer this question, other than to say both groups of patients will do well, and it's just a matter of what sort of complications or problems are you ready to anticipate and treat. And once you've sort of made the decision, that's the direction that you go. So this patient did well. Her pancreatic enzymes normalized by her 3rd postoperative day. She had an NG tube that was in for 4 days and had her drain removed and discharged home 6 days after her operation. So anyway, just an interesting case that actually was just recently in the hospital. So we'll close with this, and then I'll turn the afternoon over to our family. This is a little bit on the lunatic fringe. There's some gory photos in here, so this part's PG-13. It isn't rated G anymore. But this is a clock that works backwards, and so many of our families that we take care of wish that this was the clock that they had at home. But we never get this for trauma or other things in our life to go backwards. This was a 12-year-old girl who was shot in the face with a shotgun by her brother, and the circumstances were not, I think, malicious. It was some version of a playing around, but it happened nonetheless. And she was brought to a referring hospital and was intubated there. And again, you just have to give a lot of credit to the folks who were there, who are level-headed enough to be able to get an airway in a patient like this, because there isn't any place that sees a lot of these injuries in any given year. They put an IV in her and put her in a C-collar and sent her away and saved her life. She came to us as a level 1 trauma transfer for obvious reasons. So again, A, B, C, D, E, these are the things that in the heat of the battle, if you can sort of take your own pulse, take a deep breath, and go back to these things. You'll get yourself out of the soup more often than not. So airway, this patient had an airway, but it was a very tenuous airway at best. Breathing, she didn't have injuries externally, at least to her chest, and was oxygenating well through the tube that was in place. Circulation, she's at risk for shock, so having an IV and fluids and all those sorts of things. Disability, what's your best neurological exam? These are things that we ask every day all the time on all the trauma patients that come to see us. But the more we ask them, the better we get at asking these questions. And then exposure, looking around, what else is going on? What, despite the sort of major soft tissue injury here, what else might be going on? So she was auratrically intubated. There's a photo coming up of her, so if you're not up for that, now's your chance to leave. But she had a major soft tissue defect in her mid-face, and you can see just the destruction here to the center of her face, to the maxilla, palate, nasal septum. This was an operative photo. And then all these little pellet marks from where these shots entered the face, never to leave again. Her left pupil was fixed. Her right, she had an open globe injury. And multiple puncture wounds. She had one puncture on her neck. We took her C-collar off and examined her in the emergency department. And she had traumatic amputations to fingers from having done this, trying to get in the way of the gun, and it shot the tips of her fingers off as well. So because she was oxygenating well and had a lot going on, we did trauma things, including a chest x-ray. So here's her orotracheal tube. It's perhaps a little bit low. There may be some right upper lobe atelectasis here. And I'm not sure how well this projects, but you can see these little metallic bits down here and over here and some over here. And so even though the story was a blast to the face, what are these things doing? So we got a lateral x-ray and showed that actually these were probably in her esophagus. So these were then ingested metallic shot, and these were likely in her airways. Because she's a trauma patient, we took her to the CT scanner, and she was stable on her way to the operating room. So the Scott from that did CT of the head, face, C-spine, neck, chest, and reformats of her spine. This is a 3D reconstruction of her head and face CT, and all the little white bits are metallic shot. A very destructive injury. These are slices from her head CT that show pellets actually this is in the ventricle, and a few of these had actually gone into the brain. So we took her promptly up to the operating room to get a secure airway. We did tracheostomy, we did bronchoscopy, trying to get the little metal bits from the lungs out, but they were too far away from the bronchoscope. Because of the intracranial component, based on our head CT, she got an ICP monitor placed, and then debridement and packing of her face as best they could. This was the photo of her leaving the operating room. The ENT folks were all over this, and they did a good job of getting some soft tissue together that later became indispensable for their reconstruction. And she went to the PICU postoperatively. We'll just sort of run through her. I got to wrap it up. She had a mild traumatic brain injury. She was seen by ophthalmology and determined pretty quickly that she would be blind. She had orthopedic seer regarding the traumatic amputations of her fingers, and then really a lot of heavy lifting from the ENT and plastic surgery service to work with her face. For obvious reasons, she wasn't able to eat right out of the way. We did a gastrostomy. She developed an abscess in her brain from the dirty pellets that were there that was able to be managed with antibiotics alone and not a craniotomy. About a month into her course, she developed sort of worsening of nausea and some neurocognitive defects, and so we checked a lead level, and she had an elevated lead level. So she actually had lead toxicity related to shotgun pellets. She's only the 5th child to be reported with this phenomenon. And so just a word about lead toxicity. We think about this in the category of paint in your schools or in your home or on products made in China where there's quality control issues or whatever it is. But lead toxicity can cause, CNS is sort of the big organ that we worry about. That's a bigger issue the younger you are, the more development that you have ahead of you. But it can also have GI issues. You can get a nephropathy from it. You can get anemia, musculoskeletal problems, and infertility related to elevated lead levels. So we decided that we need to go unleaded for her. So we had one of the toxicologists see her. So at a lead level of 15, you can see cognitive impairment in children. 40 to 69 in adults. And so at 45, she met criteria that the CDC would recommend chelation for an asymptomatic patient. And she had these symptoms that were, albeit vague, but certainly could be related to her lead level. So this is the antidote for lead is DMSA, dimercaptosuccinic acid. That is a chelator, so it binds to the lead and it makes it inert. So she got that. This is a graph of her blood lead levels. So we actually checked one early on, and then again, sort of about a month into it, she developed symptoms. We checked into that one, it went up to 45. Here's where we gave her chelation. And then down the road, her levels went back up. So lead pellets that are in contact with synovial fluid, leads that are in the joint or cerebrospinal fluid, there's a higher level of absorption than if they're in fat or other soft tissue. So these were followed. They sort of ultimately equilibrated on their own. She really just had the one episode of chelation, but it seemed to work. She responded to it at least. So where do you go from something like this? She was in the hospital for 38 days and had both in the hospital and as part of her ongoing outpatient care, multiple reconstructive procedures by the otolaryngology facial plastics folks. She was decannulated for tracheostomy. She's bright, verbal, she is blind, and forgiving. She's forgiven her brother and moved on. So I saw them this spring. They'd moved out to Colorado to go to a school for the blind. Those are just not very common things, but they're out there. This is her about a year afterwards with her mom, who is just a wonderful person, was there for her in so many ways, and her brother. She learned Braille, so this is her with her little Braille typewriter. She went back to school, and she even showed up for Crazy Mustache Day. So this is her about a year and a half after her injury, and in so many ways, I think our parents our patients are our best teachers, right? We learn the most from them than the people who trained us or the people that we work with or whatever. And I think we get the privilege of working alongside kids like this and seeing really kind of what it's all about. So anyway, thanks for letting me speak. It's a lot of fun. I look forward to this conference every year. I would say a special thanks to some residents that loaned me slides and photos of some of these patients. So Myron Powell, Pat McGonigal, Jeannie Goins, thanks to those folks. And I would be happy to entertain any questions that people might have. All right. Thanks, everybody.